I'm only one call away. I'll be there to save the day. Superman got nothing on me. I'm only one call away.
Hello and welcome to another podcast. Today we're going to continue with the Director of Army Health approved medications, and we're going to look at Ipratropium Bromide. One of the drugs will be in high demands in Victoria at the moment. So looking right into it, our PCCM states that the indications for the use of Ipratropium Bromide is for acute asthma, but only to be utilised if the salbutamol treatment is not responsive. Okay, so if the type of asthma that the person has is severe enough or unique enough that it doesn't respond that well to salbutamol, or salbutamol isn't appropriate for the patient, then we're able to utilise Ipratropium Bromide. What we'll do is we'll just have a quick look, a bit of a reminder about asthma. If you want a full detailed description on asthma and other respiratory based conditions in which Ipratropium Bromide may be used, you can have a look at the presentation on respiratory pathophysiology. But looking at asthma, it all starts with some form of trigger. Now there's two different branches of triggers. It can either be an internal problem, or intrinsic, or an extrinsic factor. Now it can also be broken up into eosinophilic or non-eosinophilic based triggers. Now the way to define those is one is allergen based, and the histamine response will actually start the airway inflammation, and the other one is internal, more of a autonomic nervous system based, and that itself starts the airway inflammation. But once the airway inflammation starts, then a series of things happen within the cellular structure of the actual bronchs themselves. So we have hypersecretions of the mucoid cells themselves, and we also have muscle contraction, so smooth muscle airway contraction of the bronchs. And then we also get swelling of the bronchial membranes. Now this is twofold, because the bronchial membranes will actually spread, so the base membrane that lines the lungs will actually swell themselves, and you also over time can get hyperplasia of the tissue if you're having a prolonged swelling of the bronchi, making them more likely to be symptomatic in the presence of inflammation. Now all of these lead to narrowing of the passages and a difficulty most of the time, or initially anyway, getting airway out, and then you can have what's known as like a concrete lung sort of condition where the lungs just lose their flexibility. They just no longer respond to any breathing in or out, and it requires a huge amount of pressure or opening of these airways in order to rectify it. One of the drugs that is used to aid in asthma-like symptoms is, of course, Ipratropium Bromide. Now, the pharmacokinetics of Ipratropium Bromide are interesting, to say the least. So the predominant way in which Ipratropium Bromide is given is either via an MDI inhaler or nebulized. Now, the doses that are given are quite small as a molecular weight, and because of that, they have a very minimal systemic absorption, which is good. Okay, unlike salbutamol, which has quite a large systemic absorption, Ipratropium Bromide, if given at correct doses, is only minimal, which means they're more designed to act on the cells that they touch. They're more likely to act on the lungs than the rest of the body. Having said that, they obviously can still spread throughout the body, and we'll talk about that in a little bit. Now the onset is 15 minutes. Okay, so if you think about acute asthma, it's a little bit too long for someone to have difficulty breathing dyspnea for 15 minutes, which is why it's never used as a frontline treatment. It does last a bit longer, okay, than other treatments, not all, of 3 to 4 hours. And its peak time can be within 1 to 3 hours, depending on the dose and the means that is given. Distribution around the body also depends on the dose. You can have no protein bound, especially if it's not really systemically absorbed, but if a big enough dose is given to the right person, you can get up to 9% protein bound as it distributes through the body. Now, most of it eventually, if it does get into the bloodstream, is absorbed via the liver and excreted in the urine after a half-life of about 2 hours. So looking at the pharmacokinetics as an overview, this is a really good targeted base drug, okay, because of its minimum absorption rate and low amount of protein bounding. It allows the actual medication to work on the receptors that it's designed to work on, instead of being absorbed through the body and then spreading throughout, activating different receptors. Now, in the event that it does get absorbed into the body, okay, or a larger amount gets absorbed into the body, that's when we get the increased protein bound, and that's when you can get an increase in your adverse effects, because now the actual ipratropium is binding to different receptor sites and therefore bringing on the adverse effects. If you'd like more information or a revamp of what pharmacokinetics are and how they work, then you can check out the lesson on pharmacokinetics. Moving on to pharmacodynamics, ipratropium bromide is pretty cool, and it's good to know the difference between ipratropium bromide and your salbutamol. So ipratropium bromide is an anticholinergic, okay, or a parasympathenolytic, agent. Now, what it does primarily is it inhibits vagal-mediated reflexes by antagonizing acetylcholine actions. Now, this particular action will actually prevent the increase of intracellular calcium concentrations, okay, which means it actually stops calcium getting into the cells. So normal everyday cell, once acetylcholine hits the bronchial muscles, bronchial smooth muscles, calcium is infused, and that calcium causes the contraction, okay? So the constriction of the bronchs. Ipratropium bromide stops the calcium getting in, therefore stopping the actual contraction from happening of the airway smooth muscles. On top of that, it also binds to the acetylcholine receptors of the mucoid cells and blocks calcium moving into those cells. Now, calcium in those cells, like most cells, calcium being an amazing cation, is used to release vesicles, which actually causes mucus production. So it works on the smooth muscles, and then it also works on the mucoid cells themselves. Now, if you'd like to know more, or more importantly, how ipratropium bromide works differently from the other respiratory-based medication, then you can have a look at the generic lesson on respiratory pharmacology. Moving on into the more specifics of ipratropium bromide, we'll have a look at the warnings and the adverse effects. So the big warnings for ipratropium bromide is hypersensitivities to atropine itself or any of the ipratropium based drugs. Now, it has been known to worsen narrow angle glaucoma, so it's just a good idea to ask the patient before they have it, and we'll talk about administration in a little bit. Now, because of its pharmacokinetics that we've already discussed, we already know that it's not recommended for initial treatment of acute episode. It just takes too long before the onset kicks in. Now, certain side effects you'll get are obviously what's expected from your anticholinergic. So you get your dry mouth and your eye problems that we talked about. But because of its unique nature and the way it works that we discussed in pharmacodynamics, you can also get urinary tract infection because of flow-on effect of urinary incontinence, sinusitis because it can also stop the mucoid cells of the sinuses producing mucus, and they dry out and therefore get inflamed. It can also cause bronchospasms, and it's something to look out for, that if after administering ipratropium bromide the patient actually gets worse, you've got to stop giving ipratropium bromide straight away and continue just with your salbutamol. So bronchospasms is a quantified risk of most bronchodilators, so you need to keep watch once administering a new bronchodilator. Watch the patients. If they worsen, stop using that particular bronchodilator. As far as interactions go, because it's an anticholinergic, there's hundreds. Okay, so I'm not going to go through all the drugs and the interaction, because one, you're not going to remember anyway, and there's just too many to cover. So the best advice, if you haven't already done it, is to download the Medscape app itself. Now, I use Medscape just because it's a very reputable source, and it has a really easy to use drug interaction feature where all you do is you type in the drug that you want to give, and then you type in the drugs that the patients are already taking, and it tells you if there's an interaction. Okay, realistically, there's too many drugs out there and too many interactions of those drugs to know them all, and the Medscape app is constantly updated. You just have to download it and then re-update it when you're back with the internet, and then it can be used offline as well. Now, another particular thing to note, because you may or may not have heard it being thrown around there, but allergies to soy lectin, soybeans and peanuts is not a problem with ipratropium bromide. So if you're the older generation who learnt ipratropium bromide back in the day and haven't updated their knowledge, may still be teaching that allergies to these substances is still a problem with ipratropium bromide, but the breakdown is it was never a problem with the nebulized form. It was only a problem with the MDI inhaler itself, because it had soya-based substances within it. So therefore, people that were allergic to soybean, peanuts, that sort of thing, could have a reaction. Okay, and there was a couple of cases all the time. But recent times, there is no soya in the actual product anymore, so there's no risk for allergies. So we can stop spreading it and we can stop saying it. If you don't believe me, then you can read the information sheet on the actual ipratropium bromide medication itself. Okay, looking at dose from the PCCM 10th edition, we have two versions that we are allowed to give at this stage, based on the Director of Army Health approved medication. It's the metered inhaler's dose, 21 micrograms as an inhaler. Always use a spacer. Now, for adults or anyone over the age of 6, in conjunction with salbutamol, for using the puffer, you give 8 puffs. Okay, so you'll give your salbutamol puffs, and then you'll give your ipratropium bromide puffs straight after. If you're using the nebulized form, it's 500 micrograms for adults, 250 micrograms for children, and you just mix it into the nebulizer with salbutamol itself. Now, if you are administering the nebulizer, be very careful with the patient's eyes, especially if you're using a small patient with a large mask. As already mentioned, if it gets up into the eyes, it can cause problems to the eyes themselves, and not just glaucoma that we spoke about. It has quite a large list of irritations and problems within the eye. So either get the patients to close their eyes, or where realistically you'd have to wear tight goggles. So closing their eyes is the best idea, and shape the mask away from their eyes itself. As far as administration goes, that's where things can get a little bit tricky. So ipratropium bromide is an S4. Now, our ASI states that we need to call the MO before the administration of all S4s. Easy done. Okay, now PCCM states, as you just saw with the dose, is that the lowest qualifications, the IPAP, the IHWs, are able to give the first dose and then call the MO. Now, so we're in a situation where we follow the ASI, we call the MO beforehand, but then we can delay treatment with some of these S4s. So the best advice we can give you at this stage is to have a conversation with the medical officer that is signing you off, and just simply ask, are you happy for us to follow the PCCM? Would you prefer a call? And then essentially run with that. Okay, you may have also noticed that there is an additional inhalation solution, which is 250 micrograms per mil, that is in the 10th edition, but is currently not on the approved list, because the list was written when the 9th edition was out, meaning the solution may come into play in the future. Okay, we'll finish up with a few clinical take-homes. First of all, is if you are using the MDI, always use a spacer. Okay, now this minimises adverse effects. It's very true for salbutamol, and it's true for ipratropium bromide. Because you're inhaling it into the area that you want the most effects, most of the drug is going to be absorbed by the receptor sites within the lungs, and therefore minimising systemic effects, and therefore minimising adverse effects as well. Just remember that it is not a frontline drug, and we're only allowed to use it in conjunction with salbutamol, unless on MO's order, if salbutamol alone is unresponsive. It is an anticholinergic, So it interacts with all other anticholinergics as well as a whole bunch of other medications. So if you are giving it, because it's not an emergency drug, you have time to look up the interactions and just back yourself. Okay, just see if there's going to be a severe interaction. Now please, one to pass on to all the older generations, or one to put in your memory bank if you have been told it in the past, is allergies to soy lectins, soybeans and peanuts is not a contraindication for the administration of ipratropium bromide. Okay, that ends the lesson on ipratropium bromide. It's a nice quick one for today. The next drug that we're going to cover off on is phenoxymethyl penicillin. But until next time, take care.